that she didn't do anything else, just doing that. So we jump for the next presentation. I think one of the best-known Hungarian ultrasonographists, endoscopist, gastroenterologist is István Hritz, who we have been working for many years. I remember in the very early stage of the Hungarian pancreatic study group, I will speak about, after his presentation, a little bit about the starts and all the studies, including the guideline, EASY study, and all the other, how it started. And after that, it's really István built up a very good endoscopic center. And I am very much looking forward to understand your opinion about the step-up approach in pancreatitis.
Thank you. I'm honored to be here. It's also my pleasure. And thank you for the nice laudation from Peter. Dear colleagues, dear ladies and gentlemen, Professor Attila Szijjártó already highlighted on the need and importance of the multidisciplinary approach in the management of pancreatic fluid collections, and also Professor Zubek emphasized the need of special care in severe acute necrotizing or severe acute pancreatitis. I would like to focus more narrow in the acute necrotizing pancreatitis and the step-up approach in the management of this quite severe disorder. And our practice, which is done on the daily practice, as Attila Szijjártó already said, at the Center for Therapeutic Endoscopy at the Department of Surgery, Transplantation and Gastroenterology at Samaras University. This is the conflict of interest, my statement, and just a little bit focusing on the severity and mortality, which is defined by the revised Atlanta classification. What I would like to focus on, that what is the difference between the mild, moderately severe, and the severe acute pancreatitis. The mild acute pancreatitis, which is including the majority of patients, there is absence of organ failure and local or systemic complications. The moderately severe acute pancreatitis is defined by the presence of transient organ failure or local or systemic complications, and the severe acute pancreatitis, which accounts for 15 to 20% of patients, defined by the persistent organ failure more than 48 hours, and is often associated with one or more local complications. And this is associated with high mortality rates. And the mortality comes as an early mortality, but we have to focus on the late one. When there is a patient already in the ICU or the HDU unit, and with all the supportive care, and regardless the supportive care, there is an infection or sepsis or toxic shock or deterioration or late multi-organ failure. And this is something that we have to take into consideration when and how to approach these patients in terms of interventions. For that, we have to know the morphological aspects and the features of the acute necrotizing pancreatitis. That the necrotizing pancreatitis defined by the inflammation which is associated with pancreatic parenchymal necrosis and or peripancreatic necrosis. There is an acute necrotic collection, which is a difference between the necrotizing pancreatitis, that there is a collection which contains variable amounts of both fluid and necrosis, but it is not, it doesn't have a definable wall, doesn't encapsulate the collection, and the wall of necrosis is a matured encapsulated collection of pancreatic and or peripancreatic necrosis, which has developed and has a well-defined inflammatory wall. And this usually occurs after 3 to 4 weeks after the onset of acute pancreatitis. This is a nice picture of the possible extension routes of acute necrotizing pancreatitis. You can see that as a retroperitoneal, the most nice organ, the pancreas, and which is just behind the stomach, that it can be the perisplenic, paragastric, pararenal, and both sides of paracolic extension routes. And this is what I said, that the indication it depends on the state of the patient as well as the localization. So what are the indications? First of all, the indication when the necrotizing pancreatitis is infected with clinical deterioration. In the absence of infection, when the ongoing organ failure for several weeks is there after the onset of acute pancreatitis and the patient is deteriorating, and preferably when the necrosis has become walled off, so at least after 4 weeks. And when there is no infection, however, there is ongoing gastric outlet or intestinal or biliary obstruction due to the mass after 4 to 8 weeks of the onset, and persistent symptoms like pain or persistent unwellness in patients with walled-off necrosis after more than 8 weeks. And there is also one term, which is at the end, and it can be also associated with or without necrotizing pancreatitis, is the disconnected duct syndrome, which also needs an intervention. And this is from the NICE guideline from the IAP-APA from 2013. On the intervention mostly focuses the recent guideline from the ESGE, which recommends invasive intervention for those patients that there is a clinically suspected or proven infected necrosis. And ESG suggests the first intervention for infected necrosis should be delayed at least after 4 weeks. And by the route of percutaneous or endoscopic, and should be the first interventional method, taking into the account the location and the local expertise at the place where the patient is under care. And the ESG also suggests that in the absence of improvement after the drainage, either by percutaneous or transluminal, the next step would be a step-up approach, which can be minimally invasive surgery or direct endoscopic necrosectomy. What is the role of EUS? Definitely, there is no question now, recently, that the role of EUS in the management of acute necrotizing pancreatitis is the access to the necrotic collection, but we can nicely characterize the necrotic collection if how much of the solid and fluid content is inside. We can make the differential diagnosis because sometimes it's not easy to differentiate between the cystic neoplasia and the fluid collections. We can detect bile duct stones in patients when there is a question about the etiology of the necrotizing pancreatitis. We can detect nicely the infection of the necrotic collection. We can take a specimen, which is not recommended nowadays. We can localize and find the nice and the best puncture site. So we have a couple of dilemmas, and what we know in the last 10 years, what we collected information and what is available evidence-based, that the application of lumen opposing metal stents facilitates the transmural EUS-guided drainage. The subsequent debridement of necrotic material can be performed in a way of irrigation by a catheter or nasocavital drain and drained endoscopic necrosectomy. However, whether to apply irrigation or to apply direct endoscopic necrosectomy is unclear. And furthermore, when and how on demand or scheduled then should be carried out is also unknown. So there is no recommendation, no studies on then that how to make the step-up approach in these patients. And the last couple of years, there have been some reports about the delayed removal of the LAMS, which has been associated with an increased risk of complications, which can be sometimes fatal, and this is the bleeding. And there's also no such specific recommendation when and how to remove these stents. So this is a nice picture from Varadela from Orlando, that he compared the double pigtail stents compared with the LAMS. And it has been said that the facilitation of the necrosis and the encapsulation, which is in superior the LAMS. However, by the proximal and the distal part of the LAMS sometimes can make the usuration on the vessels and can turn into the fatal bleeding. Our aim was to fine-tune and to focus on the recommendation in the form of a local protocol to improve the safety and clinical efficacy of the step-up approach of pancreatic necrotic collections using the LAMS, with or without the cautery enhanced delivery system, and we assess the clinical outcome. So the methods, it was, and it's still ongoing project, which is a prospective study, started in the first department of surgery, which is now a Department of Surgery, Transplantation, and Gastroenterology. And we prospectively collected the data on the management of patients with the pancreatic necrotic collections. So we included patients only with symptomatic and with pancreatic necrotic collection in this study. And we had a first group when we started, then we placed the lumps with irrigation drain, and we did the rinsing through this drain for a couple of days. And the direct endoscopic necrosectomy was performed only in those cases when septic complications occurred. In the second group, we, after the lumps placement, similarly in the first group, with the irrigation drain, we routinely and scheduled, we performed routinely and scheduled the direct endoscopic necrosectomy. So these are the patients. We included 14 patients, it was 5 females, 9 males. Localization was nice because we had in the head, we had in the body, we had body and the tail, and head, body, tail. So we had all kind of localizations of these necrotic collections, and we can see that the sizes were quite big, so more than 12, 13 centimeters in average. If we look at the results in the clinical success part, the technical success rate of the lumps deployment and placement was 100%. And in the first group of 8 patients, in 1/3 of the patients, the pancreatic necrotic collection resolved without no need for them, but these patients got irrigation tube for at least 4 to 5 days. However, 2/3, almost 2/3 of those patients, after the discharge, were readmitted due to septic complications within 19 days. And afterwards, these patients underwent series of direct endoscopic necrosectomies. So it was just on demand DEN for debridement. On the second group, we had 6 patients, and we have already 2 more patients in this group. We had 2 to 4 scheduled direct endoscopic necrosectomies after the lumps placement and after the irrigation. And it usually started on the 3rd day after the endoscopic transluminal approach. And the acute readmission after the discharge was much less, just 17% in these patients. If you look at the outcome and the complication of this small patient cohort, in the first group, we can see that the average drainage time was 49 days versus 35 days in the second group, where we performed routine and scheduled DANs. The complications in terms of removal of the lumps was 0 to 0, and the late complications were also comparable between these 2 groups. However, we have to highlight that unfortunately we also experienced one fatal bleeding, and it was because of the lamps. And what we experienced at the beginning when we place a nasal irrigation tube into the lamp, into the necrotic cavity through the lamps, it has a pigtail, and this pigtail somehow defends the inflammatory wall, which is on the counter wall compared to the lamps. And in this case, without any so after removal and after the last scheduled, then we were just about to discharge this patient the next day, unfortunately died of fatal bleeding. Since then, after removing of the irrigation tube, we place a double pigtail plastic stent into the lamps, and we discharge these patients with the lamps with the double pigtail stent, and the patient comes back for follow-up. This is just a very busy slide with the endoscopic management, that how we do it in technical details. I don't want to go into the details now, but what is a big difference between the cautery enhanced delivery system, the lamps, the so-called hot axios from Boston Scientific, and without the cautery enhanced delivery system is there is no difference between the technical success in placement of these lamps. However, the timing it has a big difference, because the patients, septic patients in ICU, we can place this hot axios with a cautery enhanced delivery system in 2 minutes, in 3 minutes. However, with the old version, we have to use the cystotome with a needle knife or outer catheter with a diathermic tip after putting a guide wire and doing the balloon dilatation steps, and afterwards we can place the lamps. So it's much easier to get to have the all-in-one device. And how does it look like? This is a nice CT scan of a young patient after acute pancreatitis and a nice ward of acute necrotizing pancreatitis, which was 13 centimeters. And this is a cut version of what already Professor Severity showed us. This is the under the endoscopic ultrasonographic picture. I have to highlight and emphasize that without the need of fluoroscopy, we can apply these lamps and we can place the lamps into the necrotic collection. We can see the distal flange, which is already open, and afterwards we open the proximal flange in the stomach. You will be able to see and appreciate that how we turn our scope and get back, we will see the layers of the stomach nicely here, and this is the proximal flange, which is open in the stomach, and the distal, which is open in the necrotic cavity. And now we have the nice bridge between the necrotic collection and the stomach. And afterwards, this is the direct endoscopic necrosectomy. By a therapeutic endoscope, we can enter the necrotic cavity, and with different accessories, roadnet, Dormia basket, polypectomy snare, rod biopsy, forceps, with rinsing with a high water flow jet, and of course, everything under conscious sedation and CO2 insufflation, we do the debridement. And afterwards, this is the nice when you see that they are the drains in the stomach of the patient. One is the nasojejunal feeding tube, one is the suction tube in the stomach, and one is the tube, irrigation tube in the necrotic cavity. This is how it looks like from inside, how this stent looks like. And these are the serum CRP levels from the old study, which we performed 10 years ago, that after the debridement and after the transluminal drainage, how the CRP levels in those patients decrease. And the follow-up imaging after 3 weeks of the discharge with the lamps, we can see that that huge 13 centimeter big fluid collection turned into the 1.5 centimeter collection. And after the lamps retrieval, the patient is cured and is at home. So as I said and as I started, that the ESG has a nice and a comprehensive recommendation on the endoscopic management of acute necrotizing pancreatitis. However, there are still some questions, and there is still some debate about the timing and about the methods and how and when to do the step-up approach. And in conclusion, I would like to summarize that the fine-tuning of the guidelines may improve safety and clinical efficacy of the step-up approach in the management of symptomatic pancreatic necrotic collections, but definitely in expert hands. Thank you for your attention.
Questions?
Congratulations, really nice study. My first question is, so it means that your policies does not affected by the quantity of necrotic debris within the WOPN.
It does. So yeah, it does. So if actually I didn't put the numbers on that, but at least 1/3 of the material, the volume, should be necrotic in these patients. So those patients were included. So that's why this is like a quite a small number.
But later, of course, the randomization is not depend on the.
No, it's not. No.
And my second question is that you said you use a double lumen gastroscope, therapeutic gastroscope, which is, I think, rather thick. So is it easy to get through the? Yes,
after 96 hours, the lamps is opening in full, which is 15 millimeters in diameter, and the therapeutic endoscope measures in diameter 30 to 40 millimeters.
Congratulations, István. I would like to ask, can you use a nasocystic lavage? with an aseptic tube.
This is what we do. The lavage and the irrigation is the same.
And
Yes.
which type of liquid you
Saline.
use?
We just use the saline. Yeah.
Betadine, for example, or antibiotic.
You may actually, we did the dilution of the dilution of the betadine in saline 1 to 2000, but it didn't make a difference. And sometimes we also made the solution of gentamicin. There has been a study from the United States, but with very few cases, and it was just an abstract, conference abstract that they used so hydrogen peroxidase, but however we are not using it.
Thank you. Thank you.
Yeah. You can see, you can look at the faces of the surgeons after the hydrogen peroxidase. What does it do? Yeah.
Any other questions? Thank you very much.
Thank you.